This is course 5160, replace teeth in one visit. And the first three numbers are 5, 6, 9. At the end of the program, we will announce the last three numbers for your continuing education. I'd like to again remind you to please visit Dr. Shatkin first booth at 1417 at the end of the program. For all special attendees, there are special offers today. At this point, I just would like to let you know that Todd and I have been friends for many years. I took his course many years ago, and his company has grown pretty much unrecognizable from when he first started out. Back then, he had mini implants. Now he's up to mini. They grow a little bit. Todd has certainly had years of experience clinically and histologically and professionally, radiographically, from dentists throughout the world. He's lectured internationally, nationally, and we're really so fortunate to have had him thaw himself out from Buffalo. Please let's give Dr. Todd Shatkin a great New York dental meeting welcome. Thank you.
Thank you. Thank you, Leonard. And thank you for the kind words. Leonard and I have been friends a long time, and I ran into him at another dental meeting several months ago, and he said, he came up to me, he said, "Why don't you do some surgery at the Greater New York meeting?" And I said, "Really?" He goes, "Yeah." He said, "I'm on the committee. I can try to make that happen." I said, "Well, we'd love to do that. That would be awesome." So here we are a few months later in front of all you nice people, getting ready to present some really exciting stuff. I'm thrilled to be here. I'm thrilled to be exhibiting at the Greater New York meeting. And you all are just wonderful, and I've enjoyed meeting many of you at the booth the last few days, and I want to thank you all for your support and your attention. I also want to give a special welcome to my beautiful daughter, Juliet Shatkin. Would you stand up, Juliet, please? Juliet goes to NYU. She's in the musical theater program at Tisch, and she's assisted me on breaks during her summers and spring breaks, and so she's going to be one of my wonderful assistants here today. Along with, we have two other great assistants. We have Sunny. Sunny, stand up for me. And we also have Alina here visiting with us. And Alina, her mother, is actually our first patient. We're going to be doing a 3-unit implant bridge. Would you stand up, Vera, please? All right. So we're going to be doing 4 mini implants and replacing her upper right quadrant. Prior to this, I already put 2 implants on 2 single teeth on her, and I'll show you that on the x-ray. And we also have, I want to thank Dr. Rodney Leibowitz. Rodney, wave to everybody. Rodney's a dear friend of mine and practices in Brooklyn here, and he helped me to coordinate our second patient, who's James. James, would you stand up for me, James? And James is a very exciting case. He's been wearing dentures for 26 years, something like that. Full upper denture, and we're going to be doing what is our newest procedure in Shatkin First called a fix on 6. And it's kind of my answer to all on 4. It's called fix on 6, and we use 6 to 8 mini implants, and we attach it. It's a zirconia fixed bridge that's attached with O-ring housings, and it doesn't come out unless the dentist takes it out for cleaning. But it looks and feels like a fixed restoration for the patient. But every 4 to 6 months, if the patient comes in for cleanings, the hygienist or dentist can retrieve it, check it, clean it, and then snap it back in. So those are our 2 cases we're going to be doing today, and I'm really excited to do this. I've been giving lectures in Buffalo in my training center for many years, since about 2000, on mini implants. And we recently built a training center there that can hold 55 doctors for training with live theater and surgery similar to this, but I've never done a surgery in front of 500 or 600 people. So I'm not nervous, I'm fine, but I just want you to know this is my first experience doing this in front of such a large audience, and I'm very hopeful that everything goes very smooth. I also want to introduce to you my colleague, Thomas Fitzpatrick, who's our Director of Sales and Marketing for Shatkin First. Tom's been a great asset to my company, and he's been with us about 5 years now, and he's going to be coming up here in between the two surgeries while we're cleaning the stage and getting the next patient up to talk to you about the surgical kits and the implants that we carry and the special offers we have for you here at the show. So Tom, you'll come back up when we're ready. Thank you. I'm going to start out giving you a little background on implant dentistry and about Shatkin first, and then showing you some cases, little quick education about how the procedure is done, and then we'll bring Vera up and we'll start the first case. So what I'd like to do first is show a short video, and I think the sound is working on here, right? Good. All right, well, I'm going to show you a short video first about Shatkin first, and then we'll go ahead and do the clinical demonstration.
Dr. Todd Shatkin, the most trusted name in cosmetic dentistry in Western New York. A nationally recognized expert in mini dental implant technology, Dr. Todd Shatkin has trained over 9,000 dentists from around the world in his patented mini dental implant procedure. Dr. Todd Shatkin has personally installed over 10,000 mini dental implants, serving Western New York area patients with not only state-of-the-art facilities, but the highest quality of customer service. Dr. Todd Shatkin, award-winning skill, world-class reputation, wonderful results.
FIRST stands for Fabricated Implant Restoration and Surgical Technique. This is my patented procedure that I developed in 2002 and that well over 9,000 dentists throughout the world are now using. Shatkin First is a consulting mini dental implant laboratory. We provide free case consultation for dentists all around the globe to help you make sure your procedure goes smoothly from start to finish. We also supply you with the mini dental implants that you need for the case. After I review your case for you complimentary, I will recommend certain sizes and diameters of implants for your procedure. And we do this as a service for our customers. And then we can also provide you with surgical guide stents to help guide the implant in the proper position, and then follow through with the required laboratory procedures, whether it be crowns, bridges, or dentures for that patient's restoration.
One of the biggest things that sets us apart from other laboratories is the fact that we train the dentist on how to do the mini implant procedures. We have continuous courses throughout the year in cities all around the country. So a dentist from anywhere in the United States can find a location close to them, take a 1 or 2 day seminar, and be fully certified on the mini dental implant procedures that we offer. And then it goes beyond that. After the training, they have complete access to me, whether it's by email, by phone, or in writing. I will personally work with them on their cases and hold their hands throughout the process. Even if they're in the middle of surgery and they need help, in most cases I'm accessible to them.
At Shatkin First, what we pride ourselves on is the customer service end of our business, okay? We know that we have Dr. Shatkin, we have a superior lab, and we have a very good mini implant that we sell. But we all take pride in having doctors come out to our learning facility here in Buffalo or throughout the country, wherever it's convenient for them to come. But we want to grow with them in their practice, okay? We want them to have success placing mini implants. The doctors that work with us today are in the 90th percentile of success with us. So we want to keep those numbers up, and we want to have a long-lasting relationship. We don't want to just sell them a kit, okay, you're on your way, nice meeting you, best of luck to you. We're the complete opposite as a company. What we want to do is we want to work with you day in, day out if need be. If you need a case rushed, we'll do that. Whatever the case is, we're going to make sure that we work as hard as possible to get you the best outcome of the case. That's our goal. Your success is our goal, and we're going to stick with you through the whole process.
Dr. Shatkin's personal assistance on the implant cases are really the second to none. I start in my office at about 5:45 in the morning, and I've actually called him on his cell phone at 6:30 to ask him a question and gotten him on the phone personally. Whenever I've had issues and he's not around, there's always somebody around that can give me the answer. I've never been caught in a place where I was at a loss to do something when I shouldn't have been, because they were there to help us.
The success I've experienced since doing mini dental implants is, I can sum it up in one sentence: it's changed my life. It's made a huge difference in the impact in my dentistry, huge difference in my patient care, and has taken the stress out of dentistry by having Shatkin First Lab on my side.
All dentists should be placing and using many dental implants in their practice, because it gives them an option that they don't have with your regular conventional implants.
Mini dental implants has been the single most important practice thing that I do in my office today. Without mini dental implants, my business would be about 50% of what it is today.
I love the assistance Dr. Shatkin gives us during my cases. I've been doing the mini dental implants for about 8 years now. I've placed over 6,000 of these in the mouth with the assistance of Dr. Shatkin. I don't think I would have been able to do it without him. So it's like, again, it's changed my life and the way I practice dentistry.
I'd like to say that the Shatkin First family has been a life changer for me and for other dentists I've met in this program. It's been a life changer for my patients, and I'm really pleased to be involved with this family.
So I'm very fortunate that I have the ability to pass on what I know about mini implants to all of you, and I really hope that you'll participate in one of our continuing education programs, get on board with mini implants, and offer these great procedures to your patients, because I know they will benefit from them and they will appreciate you for it.
Okay, so that's a little background about our company. We started Shatkin First back in 2003, and we've grown quite a bit. We're international. We sell our implants all over the world, but the primary focus is the United States. Just a little background, of course you all know this, but subperiosteal implants were early implants used back in the 40s. The ramus frame implants that were used in the 50s. The blade implants in the 60s and 70s. And of course, some of these were developed right here in New York City and by Leonard Linkow and others. The mandibular staple plate implant, which of course required major surgery. Transosseous implant, you had to go in the hospital, have your mandible degloved and stay in the hospital overnight. You don't see a lot of people lining up for this procedure. You know, I don't think very many of my patients would want to go through that to have their denture stabilized. And then, of course, you have the Brandemark style implants, the conventional implants that you see all over the place that have been around since the early 80s. And there's dozens of companies out there that you can choose from to use your conventional implants, and they're all different sizes and diameters. And they all pretty much have the common theme of a two-stage surgery. You place the implant body, you wait 4 to 6 months for healing. Then you go ahead and open up the gum, and hopefully you have an integrated implant, and then you can restore it. But many times those patients need pre-prosthetic surgery before they can have the implants. They need ridge augmentation, they need sinus lift procedures, they need ridge splitting procedures, onlay bone grafts, all kinds of different things. And by the time you talk to your patient about all the things they need to get the procedure done, first of all, they've lost you, you've lost them, and second of all, they don't want to go through it most of the time. So I found out, you know, I started in 1989 in practice with my father, who was a DDS MD, board certified plastic, reconstructive, and maxillofacial surgeon and oral surgeon. And we did all the implants together for the first 10 years of my practice. And we did the bone grafts, and we did the sinus lifts, and we did iliac crest bone grafts, and we did all kinds of ridge splitting procedures, and osteotomatic sinus lifts, and everything you can imagine I've seen working with my dad. We put blades in, we took subperiosteals out, we did the Brandemark clones, we did, you know, Stereos, we did Bicons, we did all the other, a lot of different companies' implants, LifeCore, and oh gee, I can't remember all, Calcitech, and they're coming back to me now. And we did those for many, many years. But around 2000, around the end of 1999, I got introduced to the mini implants. And I didn't know if I could believe these things could work. And I went to my father, I said, do you think these things really can work? Do you think we can really put 4 mini implants in the lower jaw and stabilize a denture in an hour? And we looked at this video that came from one of the companies that made the implants, and we watched it, and we looked at each other and we said, let's give it a try. What do we got to lose? So we went ahead and ordered the kit, and we learned from a videotape, because that's how they were teaching back then. And I started trying out these mini implants. And I did my first case, a lower denture stabilization, in 1999, and we stabilized the lower denture, and it went like clockwork, and it was done in about an hour. And the patient came back a few days later and was doing really well. And then another week or two went by, and she was still doing well. And I was like, wow, this is really something. Because all these years I'd been doing this major surgery and waiting 6 months to a year to stabilize the denture. And now I could do it in one visit. So I started advertising and promoting it, and we started doing a lot of them. After about 6 months of doing lower dentures, I said, well, if they work so well in the lower denture, why not try them on the upper jaw? So we started using them on the upper jaw, and I started doing upper denture stabilization and cutting the palate out of the denture so they could have a horseshoe design. And we put 6 minis on the upper because I felt that it was a bigger jaw and a bigger denture and they needed more support. But we were using 6 and we were cutting out the palate. And I did those for about a year with the lowers and the uppers. And after about a year and a half of doing mini implants for dentures, maybe 2 years, around 2002, I got the bright idea, why not try these on a single tooth replacement? And so I had a 15-year-old boy who had congenital and missing lateral incisors and had very little space and was tired of wearing his partial. And we put 2 mini implants in and we replaced those teeth with crowns. Those implants, we put mini implants and then we put permanent crowns, or actually at the time I used resin crowns because the kid was still growing and I didn't want to put permanent crowns on. I put just composite resin crowns on him. And would you believe, and this child was a good friend of my son's. They played hockey together, and this is going back to about 2002. Would you believe he's still got those implants and teeth in his mouth? I've since replaced the resin crowns with porcelain crowns, and the kid's 21 years old now. So, actually 23 years old now. So these mini implants work. So once I did him, I said, well, why can't we have these crowns made in advance and make a surgical guide to position those implants in a pre-planned position and cement the crown on in one visit? So in 2003, I applied for a patent on that procedure and started First Laboratory at that time, and that's when we started this business. Since then, like I said, it's grown dramatically, and we have thousands and thousands of dentists using my procedures around the world. But it's exciting to know that, but what's more exciting to me is the number of patients' lives that I've changed. Not just in my own practice, but if I have thousands of dentists performing this procedure on their own patients, we've changed a lot of lives, and that's really what makes me proud and excited about mini implants, about the procedure, and what you can all do for your patients. Because when was the last time a patient came to you and had a 4-rooted molar root canal done, and after she was all done, she came up and hugged you and thanked you and said, this is the best dental visit I've ever had? That doesn't happen very much, does it? But when you stabilize somebody's loose denture, they come back a few days later and they are just so gratified and so happy about what they've had done. Or if they've had a few missing teeth for several years and you have that procedure done, they're very excited about it. So I'd like to ask you, let me have a show of hands of how many of you place implants in general, place the implants in your office. Looks like maybe a third of you. How many of you place mini implants? Raise your hand real high. About not too many, really. So how many of you have never placed an implant in your life? Okay. Well, I will tell you that if Gordon Christensen were here, he would tell you that if you're a general dentist and you're not placing mini implants, you're really missing out on a great thing, because this is changing the direction of implant dentistry. So we know what conventional implants are like. Let's talk about what mini implants do. The actual inventor of the mini implant was Michel Cherchev in France in 1966. But he never really marketed the implant because he was a little bit ashamed of the idea of just putting a screw in someone's jaw. He used it in his own practice. Well, around 1999-2000, they began to be marketed, and originally they were marketed as transitional implants to help stabilize dentures for short term. And they were considered a simple, cost-effective solution to stabilize a loose denture. But after a few years of doing these, in 2003 and 2004, we had enough cases that I had done in my practice to help submit the evidence to the FDA to get long-term approval. And in 2004, we got what's called ongoing approval, which means you could use these for ongoing use. Whatever that means, I don't know, okay? But it meant it was something longer than transitional, but it wasn't quite to the long-term status. So we kept working with the FDA, and we eventually got long-term status approval. I believe it was in 2005 or 6. And then we worked on Healthcare Canada to get the approval in Canada, and they used all of my studies to get these approvals in the US and Canada, and then eventually in the European Union. But there's been continuous improvement in the design of the mini implants, and now they're used both for denture stabilization and crown and bridge on a regular basis. And the FDA has accepted these again for long-term use. Mini implants have become extremely popular over the past several years, and like I said, Gordon Christian's a very strong supporter of mini implants, lectures on them, has his own videos and all kinds of different things about mini implants. He's a strong supporter of our mini implants. He's given 2 lectures with me in Buffalo, and we'll probably have him back again next year to talk about the Intralock Shatkin mini implants. What are the advantages of mini implants over conventional implants? Now, when I would present 10 cases for my patients in my office, back before I did mini implants, I'd present 10 treatment plans for implants, and out of those 10, 1 or 2 patients would say, okay, let's do it. Why wouldn't I get more than that? It was a long process, it was uncomfortable, it required many office visits, it cost a lot of money, and there was a fair amount of discomfort after the procedure and healing period. And they didn't want to go through all that stuff. You know, they can tolerate maybe 1 or 2 out of those 5 things, but when you give them all 5, it's pretty much easy for them to say, no, let's do something different. But the great thing about mini implants is there's no waiting period. We don't have to graft the bone in 98% of the cases. We almost never have to do a sinus lift. They're FDA accepted. The cost is about half the cost, and it's a non-invasive, non-surgical technique. And when I say non-surgical, we're not raising a flap in the vast majority of the cases. There are occasions where there's a very knife-edge ridge and a very thin ridge where you have to raise the tissue, but it's very far and few between, and I certainly hope we don't have to do that today. But in all honesty, it's a very simple procedure. It's easy for patients to accept it. Again, the results are immediate. We can do immediate loading. They're designed for immediate loading. And why are they able to be loaded immediately? Because these mini implants are 2 millimeter, 2.5, and 3 millimeter design, and we use a small pilot hole to make the initial hole. We don't make an osteotomy. We screw the implant into the bone, and it's anchored and secure right off the bat. There's osteostability immediately. And with the Osteon calcium phosphate coating, we get very fast healing of bone. 2 to 3 weeks. In 2 to 3 weeks, we get bone integration. So this is why mini implants work. It can be used on almost any ridge. There's very little post-op discomfort. Most of the time, just Tylenol or Advil is all the patients need after the surgery for a day or so, and that's it. There's a tremendous profit potential for your practice, and there's a very minimal upfront investment. And Tom will talk about that a little bit later about the investment, but really for about $2,000 you can get started placing mini implants. We use them again for stabilizing upper and lower dentures, for single teeth replacement, multiple teeth replacement, and even roundhouse bridges. And I see in the audience I have a lot of people, dentists that have taken my course before. I'm just looking around. How many of you were trained with me over the years? I've been doing this for 12 years. Raise your hand if you've taken my lecture in the past. Well, thank you all for coming back again. I appreciate that very much. And again, the mini implants come in 3 diameters, 2.0, 2.5, and 3.0. They're available in lengths from 10 to 18 millimeters in length. The implant and the abutment are all one piece, so there's no moving parts. And of course, we include the O-ring housing with the implant, which a lot of the companies don't. You have to buy that separately, but ours are included. And the biggest thing that's great about the Shatkin implants is the independent studies have shown that our implants are 30 to 40% stronger than the competing implants. Why is that? Our implants are slightly bigger. They're a 2.0, 2.5, and a 3.0 as opposed to a 1.8, 2.3, and a 2.9, or variations of those sizes. And we also have a different thread design which prevents fracture. So the tensile strength is 78 Newton centimeters before it will break, which is very, very high. And I'm going to show you a little bit later how the aseptico motor measures the Newton centimeter torque during placement. And that's very, very important to know what your implant is going in at and the amount of resistance you're getting in bone, because we want to have at least 30 Newton centimeters of torque during placement to load these immediately. The great thing about mini implants is you get that almost all the time. But if you don't get it with a 2 millimeter mini implant, all we need to do is take that 2 millimeter mini implant out and replace it with a 2.5 or a 3.0, and then you'll get that resistance that you need to load it immediately. So those are all the kind of the things that we teach in our 2-day course. You know, this is a very short seminar and then a live surgery, but I encourage you to come to Buffalo or one of our other cities where we're doing our full 1- and 2-day courses, and you'll learn about all the nuances of mini implants. And one of the things that I guess Tom is going to talk about later is anybody who buys a starter kit here at the show is going to be invited to come to our 2-day training course at no charge, which is a $1,000 value. So I'd love to have you come to Buffalo. You'll see our lab, you'll see our training center, and really get a good idea of what we do with Shatkin First. But that does bring us to, I did mention Aseptico, and I want to thank Aseptico Corporation for helping sponsor these programs that I do. They're wonderful people. They've got terrific products. I've got 4 Aseptico units in my office. They never break down. They just keep running and running. It's like the ever-ready battery. They just never die, which is a great thing. And if you ever have a problem, they give you great service with them. So, but anyway, the implant and the abutment are one piece. The housing's included, and they're stronger implants. This is our pivotal article that we published in 2007 from Compendium. This is really what put mini implants on the map back in 2007, because all the oral surgeons and periodontists, do we have any here? Raise your hand if you're an oral surgeon or a periodontist. Come on, nobody wants to admit, or there really not anybody here? I'm just kidding. No, we got a lot of criticism. We got criticism from the oral surgeons, the periodontists who didn't believe in mini implants, or didn't believe they worked, or didn't want to believe they worked. And they kept saying, publish or perish. That's what I got. Publish or perish. Show me the evidence or stop doing these things, right? I was fighting an uphill battle from 1999. Finally, in 2007, we had a 5-year retrospective study to show the long-term success of mini implants. And we had 94.2% overall success with 2,500 mini implants placed. And at that point, we had something published that was acceptable and peer-reviewed, and that helped our cause quite a bit. In 2012, we did an 11-year study showing 5,600 mini implants placed over an 11-year period, and this is the breakdown we had. We had approximately 58% of those implants were for fixed restorations, about 40% for removable restorations, and we did a comparison. We showed that the Intralock MDL had a 94% success rate as opposed to the MDI of a 90%. Both of them are acceptable success rates. And this is overall individual implant survival rates. But what we have to remember when we do mini implants, we put a series of them in usually for an overdenture. So if you have 6 in the upper jaw and you lose one, the denture still snaps in. You've still got a stable denture with 5 or 4 or whatever we have. So we actually have 98% case success with mini implants. Now go out there and show me any other implant system, I don't care what size they are, that has better than 98% case success. You're not going to find one. So mini implants work and they last and they're very functional, but they're also easier for the patient and they're less expensive. The average time until a mini implant would fail would be 5 months. Most of them fail within the first 5 months if they're going to fail. which means if you get past that threshold, the chances are very good that they're going to be in for a long, long time. And I've got cases of, like I said, 14 years old that are still perfect. In fact, we actually see bone growth around the neck of these implants, not bone loss. Why would that be? Why would we see growth around them? Why don't we get saucerization around minis like we do with conventional implants? The reason is when we do the surgery, we're not raising a flap, we're not making an osteotomy, and we're not taking away blood supply to the bone at the crest of the ridge. And that's my theory, and I believe it's accurate. We have higher success rate with smokers, a little bit. And if you look at this, you'll see that 98% of our fixed restorations are successful. About 93% of our lower dentures successful. And upper dentures have the highest non-success with minis. We have 83% success, about 16% failure of the individual implants. But, like I said before, we put 6 in just in case one's going to fail. And we still have 5 left in almost all the cases. It's very rare for more than 1 or 2 implants to fail on a case, and you can always go back and add 1 or 2. And the patients are aware of that, and it's not a problem. So in 2006, Gordon Christensen said the mini implant has arrived, and again, if you saw him today, he'd tell you you need to be doing these things. Now, maybe not everyone's does everything Gordon Christensen says. Certainly we don't have to, but he's certainly been around a long time. He's actually a prosthodontist. He really believes in mini implants, and he really believes that general dentists should be doing implants. So I want to show you a case here. This one is an upper and lower edentulous case, and Shatkin first made the overdentures and the surgical guide stents. Now, when you send a case in to our laboratory, you send us either your panoramic x-ray, your models, or intraoral x-rays, or a CT scan. Obviously, CT scans will give us the most information, but 95% of the dentists who work with Shatkin First don't have CT scans available to them. How many people here have a CT scanner in their office? Anybody? 1? Okay, so prove my point. Most of you have Panorexes, right? Vast majority of you probably have a Panorex in your office. So 95% of our dentists send Panorexes and intraoral films along with good quality impressions, and we review the case. And what happens is every single case that comes in, I personally look at, I plan the case and help design the surgical stent. And that's what I was talking about with holding your hand. We make sure the case goes smooth once it gets back to you. So when you get the case in your office, all you really have to do is put the stent in the mouth, drill your pilot hole, screw your implants in, and replace your denture. So the other thing that we do is we hollow out the denture in the areas where the implants are going to go. So you have very little chair-side adjustment to do. So this is a technique. You're going to take your surgical guide, you mark the locations with a Thompson marking stick, and I want you to verify the position by looking at it and confirming that you're happy with the position of the implants. Once you've done that, you're going to give your anesthesia, and I usually use the wand for my anesthesia, and I'm going to be using the wand today, the STA wand, and I usually use Septicane for my local anesthesia. I infiltrate on the buccal and the lingual area of the arch and a little bit on the crest. We don't need to give a nerve block, and we don't recommend it. It's always better for the patient to have continued sensation of the nerve bundle so that if you get anywhere near the nerve canal, they'll let you know. And then you can back it up, take an x-ray if you need to. The pilot drill guide instrument is placed into the surgical guide stent. Your pilot hole is made. Your implants screwed through the surgical stent. Again, they come in 3 diameters, and we'll advise you on what implant size we recommend you use. There's the implant screwed in through the stent after the pilot holes are made, and there's the implants in place after the stent is removed. Next thing, we put these O-ring housings on the implants, and then we go to our denture and pick the housings up with our reline material. There's the denture again, hollowed out for the O-rings, and we use our own resin reline material to pick the housings up. You squirt that in there. You can do this for a whole reline, or you can just reline the areas where the implants are, and it takes 5 minutes in the mouth to set up. After 5 minutes, you have the patient bite for 5 minutes, not hard, not soft, just normal. All right? Lift the denture out, and then you will have the 4 implants housings come out in the denture, and then all you have to do is trim the excess flash around it. Again, we're going to do the same thing on the upper. Put the upper surgical stent in place, mark the locations of the 6 implants, drill our pilot holes. Obviously, we have anesthesia at this point. We're going to put the 6 implants in, and there's the 6 implants in the upper denture, and there's the post-op Panorex x-ray. Are there any questions I can answer on denture stabilization? There's microphones up here if anyone has any questions on overdentures. Just come on up. Yeah. I can't hear, I'm sorry. If you have good post-dam suction. Well, no, if a patient's comfortable with their upper denture and you've got good suction, there's no reason that they have to have implants. But what they like about the implants is they don't have to have the palate covered. You can cut that entire plastic off the roof of the mouth and give them a horseshoe. What I find is patients who have lower dentures stabilized are the same ones that want to come back and have the upper ones done later because they're so happy with what we did on the bottom. And they say, oh, I can get the palate removed from the upper. And as soon as you show them a model of an upper denture with a horseshoe palate, they say, I want that too. You know, and so that's why we do those. Are there any other questions? Yeah, over there. Yeah, let me touch on that. The mini implants, because we were looking at a 2-dimensional film, and I'll show you a CT scan a little later of a different case. We don't normally do sinus lifts because we angle the mini implant a little toward the palate, and we avoid the buccal sinus cavity. The mini implants are so narrow that we can sneak them in behind the sinus cavity at about a 10-degree angle. And I'm going to show you how we do that a little bit later. But in most cases, we don't need sinus lifts. And even if you push the membrane up a little bit or even perforate the membrane a little bit with a mini, you get bone growth. 6 months, a year later, you'll take an x-ray and you'll see a tent of bone on the top of it. It's really something else. It's like an osteotome sinus lift. It's very much like an osteotome sinus lift. Yes?
So it's only dental stabilization, it's still tissue loaded?
Yes. These dentures are tissue supported and implant retained. That's why the O-ring itself has vertical and horizontal forgiveness. Yes. Hang on. What's that?
Do they make these implants with screw holes in it if you want to use a screwed-in case?
Well, Intralock Shatkin does not, but I'm sure there's some out there that you can use that for. My experience is it's usually the screws that loosen up and cause problems when you do screw-retained procedures. I personally like cementing them better. I get better success and less crowns and bridges loosening up with cement. All right, I'm going to hold the questions till a little bit later, and we're going to continue on now. As far as the crown and bridge on mini implants, that's the next subject. I'm going to talk about my single-stage first technique, fabricated implant restoration and surgical technique to replace a single tooth. Here's a patient that's missing a bicuspid, and you can see from this picture she's had a lot of bone loss on the buccal wall, buccal defect. If we were to do a conventional implant here, of course you'd have to do bone grafts, onlay graft, or something to build that bone up. But because we're using a small diameter mini implant, we can angle that implant a little bit toward the palate and grab that palatal bone and avoid the buccal concavity. So Shatkin first made a surgical guide as well as a single crown, zirconia crown. Excuse me, I'm just going to get my water here. And this is all made in advance. Like I said, the porcelain crown is made in advance from good polyvinyl impressions and a bite registration from your office. Now, you don't have to do it this way. If you're more comfortable doing it in 2 stages, by all means, put the implants in, take the impressions, send it to our lab, send it to your lab, do a CEREC crown, whatever you want to do on it to restore it, it's up to you. But this is one of the things that we offer is immediate tooth replacement. What I found is it's a big practice builder. Patients come in, they get their tooth in a day, and they go out and tell people about it immediately. And then other people come in. So here we have our surgical guide, our porcelain crown. We make our pilot hole just like we did for the denture. We screw the implant into the bone. Now we can either use the motor to place the implant or finger instrumentation. I personally like to use the motor the best, and so I use the Aseptico motor, and that's what I'm going to use today to place my implants. I may get a couple of them started by hand and then finish them with the motor, but I usually use the motor to place all of them. And here's the implant all the way in place, and there's our crown cemented in place with our resin cement, and there it is cleaned up. And there's your patient finished with an immediate tooth replacement in about 20 minutes. Now for molars, we usually use 2 mini implants. You can get away with 1 3mm, or you can use 2 2.0s or 2 5s. In my personal practice, I like to use 2. I believe we mimic anatomy the best by giving it a mesial and a distal root. In this case, we did a mesial and distal root at a little angle because the space was a little bit tight there. And we went ahead and placed 2 implants and a permanent molar crown. Here's our pilot hole and our 2 implants in place. And then we go ahead and cement the crown. That's a PFM that was done a while back. Most of the crowns we do now are all zirconia restorations, either solid zirconia or layered zirconia. In the anterior, we like to use the layered because of the aesthetics. Posterior, we can use solid one-piece zirconia restorations. Here's the crown cemented in place. That's all the bleeding you get from this procedure. Very little bleeding. We're just making a tiny little pinhole in the gum. There's no cutting, no surgery. Here's another case with 2 bicuspid teeth. And we're going to go ahead and make our pilot hole, screw our implants in again, and there's the implants in place and the crown cemented. Now I mentioned we also have our one-piece design implant that doesn't have a ball and square, and it's a tapered abutment, which you can use on these cases as well now. So if you're a little uncomfortable cementing crowns on balls and squares, then use our one-piece tapered abutment. I don't have a problem cementing on a ball and square. In fact, I think you get a lot of retention from the undercut in the ball, and you get the anti-rotation from the square. So this is a post-op x-ray on that patient. I did her conventional implants 12 years earlier, and she couldn't believe the difference. 12 years earlier, I did a sinus lift, bone grafts, and then did her implants, and it took about 9 to 12 months to finish. And then here we did this procedure in about a half an hour. So you can imagine the patient knowing the difference, having them both done was like, wow, why didn't I have this done 12 years ago? Well, it wasn't available, but you know, she was very, very excited about the end result of that. Now this patient had a full upper partial denture with wire clasps, palatal coverage, and didn't like it. So what we did here is we made 2 3-unit bridges with surgical guides. Here's a surgical guide stents with the 3-unit bridges, and we went ahead and did this. Now, if you look at this, you do a little bit of the math in your head. I don't know how much you charge for a crown around here, but I charge $1,300 for a crown and $1,300 for an implant in Buffalo. The range around the country is anywhere from $900 to $1,300. On this case, I did it a few years ago, and I was charging $1,200. So this was a $14,400 case I did in my office. And we had it done in less than an hour. 3 implants on each side, and the crown cemented in about 45 minutes. And this patient was so happy. The patients are so happy to have their procedure done quickly and affordably, and they can leave and have all their teeth replaced. This would cost a lot more if they went to the oral surgeon, had bone graft, sinus lift, conventional implants. And they'd have to go to multiple offices and, you know, that whole thing. Here's another case, similar, lower case, 3-unit bridge with 3 implants. And there's the bridge cemented in place. And there's a post-op x-ray. I'm going to show a couple advanced cases. This is a patient, a young man, 22 years old, who had multiple congenitally missing teeth, upper and lower. You can see from the picture that the upper left canine drifted distally, and the upper right canine drifted mesially, and then he's got a little bit of crowding in the 2 front teeth, and we're going to do some cosmetic and implant dentistry for him. He didn't have enough money to do his bottom teeth at this point, but you see what happens when you don't have teeth, you don't develop the bone. And so you see a large buccal defect on the right side, a pretty good buccal defect on the left side, and especially on the mandible, which we weren't even doing, and also in the anterior, the ridge is very narrow. So he's an ideal candidate for mini implants. What we decided to do was 4 porcelain veneers and 6 mini implants. And we decided to turn the left canine into a bicuspid. So we went ahead and did that procedure, and this is how he came out. And this was 2 visits, 2 weeks apart, start to finish. And you can imagine how happy he was after his teeth were restored in 2 short visits. If this went to an oral surgeon, they would do bone grafting, they'd wait 6 to 9 months, they'd put the implants in, they might do sinus lifts, and this kid would be another year before he had his final teeth. And he probably wouldn't have the money by the time it came time. How many of you have patients that have implants sitting in their jaw for years? Don't you have that? They can't afford to restore it after they paid for the implant surgery. There's nothing left. They gave it all to the surgeon. They thought that that was all inclusive. They come back to you, they say, oh, I thought the crown was included in that $5,000 for that one tooth. No, I'm sorry, it wasn't included. I got to charge you another $1,500. And they give up. I get them all the time, people coming to me with implants sitting up in their jaw. They've had them there for 5 years, 10 years. So you get them done quick, you get them done affordably, and they're very, very happy. And this is one of the last ones I'll show. This gentleman came to me 2 weeks before his daughter's wedding. He said, can you get me some teeth? I have enough money left over after I paid for the wedding. I want some implants done to get these done so I can eat at my daughter's wedding. Can you get me some teeth in 2 weeks? And I said, oh boy, that's a tough one. I said, well, it'll be $17,500. He said, no problem, here's a check. He wrote the check, and I said, okay, we'll do it. So we went ahead and put 10 implants in and had his implant bridge done in 2 weeks. He needed work on the bottom, and he promised me he'd come back, and he did come back after the wedding, and we did perio-scaling and fillings. But here's his permanent upper bridge, porcelain, pink porcelain over zirconia bridge, cemented in 2 weeks. And then this other lady came out from Dallas, Texas with her dentist because her dentist had this patient who wanted to do a roundhouse bridge but had never done a mini implant, and she wanted to do it in 1 visit. And I said, you know what? You should come to Buffalo and bring your patient with you because this is a tough case. And it's kind of what we're going to be doing today on James, slightly different. But so she came out. She lost all her teeth at 25 years old. This is 10 years later. She's 35. She had well water where she grew up and lost all her upper teeth. We went ahead and had a permanent 12-unit bridge made and a roundhouse surgical guide stent made in advance without ever seeing the patient. And she came in on a Thursday. On Friday morning, we did her procedure, placed the 12 implants and cemented her permanent upper bridge. And this is her immediately after surgery. We took her out to dinner at the Skylon Tower in Niagara Falls for dinner that evening on Friday night. And we took her to breakfast the next morning at the Pancake House, and then took her to the airport and sent her back to Dallas. Well, 3 months ago at the San Antonio meeting, I did this case in 2003. And 3 months ago in San Antonio, the ADA meeting, I saw the dentist, who's her dentist, and asked her how she was doing, and she said she's doing fabulous. Actually, it wasn't even 3 months ago, 2 months ago. She's doing fabulous. This is now 11 years later. She's never had a problem. I've personally done about 300 roundhouse fixed restorations on mini implants and had very, very few problems. I think we only had one case that was a total failure that I had to redo a denture and an overdenture, but they work out, they work very well, and they hold up very nicely. So the FDA's accepted these for long-term use. The ADA's accepted these for marketing purposes. So why won't you accept them? You should accept them. They're going to work wonders in your practice and in your life. So, Sonny, I'd like you to come over and bring Vera up and get her situated in the chair. And I'm going to take a few questions. Are there any questions? Yeah. Tom, can you help us with the microphone? Juliet, bring the microphone to whoever has any questions here while we're getting things set up.
I noticed on the post-operative x-ray that it's kind of square as the crown comes into the implant. How is the patient able to get up underneath there and maintain that clean?
You're talking about for the roundhouse bridge or for the single teeth? Yeah.
Any of them.
We give every patient a water pick with every case, and we show them how to floss. We give them floss threaders as well as proxy brushes. And they get up under it and they go around the implants and they do clean. But the best tool they have is the water pick. And we use the tooth tonic, the tooth tonic rinse that they put in the water pick, and that works very, very well. But I will tell you that I have patients that they don't want to come back to the dentist. They miss their cleaning for a year and a half. They come back, half of their teeth are natural teeth, the other side are all implants with mini implant bridges on them. The side where the teeth are, the gums are inflamed, they're red, they're bleeding. The side where the implants are perfectly healthy and pink. The tissue stays healthy as long as they brush and rinse and irrigate. Yep.
Another question. If one or two implants in this fails and you've cemented this in, how are you going to get it out to take out those implants and then Pontic out of there?
Well, that's a good question. So what we do, and I throw the question back to you, if you did a roundhouse fixed bridge on natural teeth and you had a root crack or something happen where you couldn't save the root underneath one of the teeth, what would you do? Well, what I would do is I'd make a little flap, I'd cut that root off, and I'd remove it. And that's what I would do in a roundhouse situation if I had an implant that was failing. However, it almost never happens. Almost never happens. But an answer to your question is exactly why we came up with the Fix on 6 procedure, which we're going to be doing for James today, which is a roundhouse fixed bridge retained with O-ring attachments. The patient doesn't take it out, but the dentist can retrieve it to inspect it and check it on a regular basis. And that's kind of where we're heading with the roundhouse restorations. Are there any other questions? Yeah, right here.
How do you get the, when you put those implants in and you have a prefabricated bridge or even a crown, how do you get the...
positioning?
The four sides.
Yeah, so the implant itself does not have to be in any specific position because the hole in the crown is cylindrical. There's some corners to it to prevent rotation, but the hole in the crown is a little larger than the implant, so the implant can be turned in any direction. The cement retains it. Okay? All right. We'll take one more question here. We have very little cement problems with washout, very little. The resin cement hardens up very, very hard. And like I said, I actually have fewer mini implant crowns loosen than I do natural teeth crowns loosen. For whatever reason, I don't know. But I re-cement a lot more natural crowns than I do mini implant crowns. All right, we'll take one more question before we start the procedure. Anybody else? No? Yeah, over there. What we do for vertical dimension and centric occlusion is exactly the same thing I would do for any other prosthetic case. If I'm making dentures, if I'm making roundhouse, if I'm doing crown and bridge, we take good vertical dimensions. We take a wax bite. We make the midline. We can use Facebook transfers if you want to. Whatever you would do in your own practice to develop the centric occlusion and vertical is the same thing you're going to do here. There's nothing different in the prosthetics. And there's probably 20 different ways to do that. And, you know, this is not a prosthetic course, but I'm sure you know how to do it your way. And this gentleman does it a little differently, and I do it differently. But whatever technique you're using to make your full dentures is how you would do it here. Same thing. All right? Okay, so we're going to go ahead and get things started here for our procedure. Before I do that, I want to just show you the x-ray of this nice lady, Vera, who's in our chair. Now, you would think, again, that we might be up in the sinus here, wouldn't you? But if you look at the cross-section of that, you'll see on the upper right side that we're actually very, very, I'm sorry, let's see if it's showing up here. In the next x-ray, now you'll see that we're actually, on the lower left corner, you'll see that we're actually short of the sinus. Okay, because that's a cross-section right through the implant. Although there's overlap when you get a panoramic view because of the buccal overlap of the x-ray when you go right where the implant is, and you'll actually see a little tent there. Do you see that? A little bump above that implant. So when I plan the cases, I plan your cases the same way I plan my cases. I measure, and I pick the implant that goes in the right spot, and I tell you what size to use. And I can tell you that we've been doing this now since 2003, and we have extremely good success rate with our doctors, about less than 3% remake of the restoration. So here's what we're doing. We did the upper and lower bicuspids on her before, and you see the lower one goes right down to the canal, but it's about 2 millimeters short. today we're going to be doing the upper right. And you may say, yeah, there's a very low sinus there, and there is on the upper right side. So we're going to be doing 11 millimeter mini implants, but the interlock Shatkin implants, 11 millimeter implant has 9 millimeters of threads. So we're using a 9 millimeter threaded implant to restore the upper right, and we're going to be putting 4 mini implants in and a permanent bridge. Thank you. With betadine? Where's my gloves? Okay. So my tremendous staff has already prepped the patient. They've cleaned the patient's makeup off, and we use betadine to do that. If they have an allergy to iodine, you would use something different, like maybe chlorhexidine or something like this to wash off the makeup, as well as inside the mouth. And do I have to have that picture right on top of my bald spot? I didn't realize I was that bald. Jeez. It's starting to look like my father. Let me bring this over. I'm kidding. You can do whatever view makes it the best for the audience. Let's see here. I like to do my oral surgery standing up, so I don't know what you guys all prefer, but I'm going to stand up for the procedure here. Whoops. Let's see, I gotta get used to this chair. Okay. Are we okay like that? How are you doing? You okay? Yeah. All right. So what we've done is we've had, I'm going to get her numb in a second, but we have this fixed bridge here, which is fabricated in advance. And you can see the holes underneath. And the restoration, it's a full zirconia with layered porcelain on it. I'm just going to try it in for fit, and I've already done this back at home, but go ahead and bite together for me. Bite. Turn your head that way a little bit. And you can see the bridge is seating all the way. And it looks real good. My light's a little bright, I think. Let me turn it down a little bit. Open. Go ahead and take that out. We're also going to try in the surgical guide stent that we had made in advance. Here's that surgical guide. This was made from a CT scan. You don't have to make them from a CT scan. Like I said, 95% of the cases we do for other dentists are non-CT guided, but this one was designed on a CT program and merged with a model, and then digital models were printed, and then we made the surgical stent with the implants in the digital model. So what I'm going to do now is just anesthetize her with the wand. And I like to use Septicaine primarily. Occasionally we use lidocaine or something different, but usually Septicaine. You put topical on, right? And we're going to go ahead and get her numb. Little pinch. What's that? Did you say something? And I'm infiltrating on the crest, buccal to the crest, and a little bit to the palatal of the crest. Not very much at all. And what's nice about the wand, of course, is there's very little discomfort to the patient. Takes a little bit longer, but it's very, very nice and kind to the tissue. And we're going to use one more carpule. Tip your head up a little bit. I like to sneak up on the palatal injections from the buccal, so you do the buccal first and then do the crest and then a little bit on the palatal side. You feel that? Any pain? No? Good. Okay. So she should be nice and numb now. I'm going to rinse you out a little bit. How's the picture? Good? Maybe I can lay her back a little more. I don't know why it doesn't want to lay back more. Let's see. No? Okay. All right. Chin up. Okay. Well, let's come from underneath so they can see the ridge area where I'm working here. There you go. Now, on April Fool's Day this past year, I came into work, and Sunny and her other colleagues handed me this mirror on the first patient I saw. I asked for a mirror and Explorer, and they gave me this big, huge mirror. I've never seen anything like it before. But then I got to thinking, this would be good for training purposes. So I can show you guys. I don't even know they made mirrors that were 2 inches wide, but I was like, what the heck is this? But anyway, this can give you a little better view of maybe what's going on in the patient's mouth here. I don't know. Maybe it does, maybe it doesn't help. I don't know. Anyway, we'll see. I'm going to try to use this Optigate. I'm not the best at it, but I'm going to give it a try and see if it works for me. Okay. Does that help a little bit? Good. Okay. So now we have our aseptico surgical motor, and we're all set to go ahead and place the implants. And we're going to use a 1.2 millimeter pilot drill. Where's my new pilot? And this is a single patient use pilot drill. And we take this out of the package, and we can use it for as many holes as we need for the one patient. But after that, we dispose of it, because by autoclaving these, they can become brittle and break, and you don't want those to break in the patient's jaw. So it's a single patient use. We open a new one for each case. It's a 1.2 millimeter pilot drill. And remember, I mentioned earlier that the implants are 2.0, 2.5, and 3.0. And in this case, our plan here is to use 2.5 by 11 millimeter implants. Take the rubber band. So we're using the MDL 2.5 11, which has a 9 millimeter threaded portion and a 2 millimeter collar. I'm going to go ahead and place our surgical guide stent in the patient's mouth. I'm going to ask Sunny to hold part of it still there in the front. Move your finger to the front here. Okay? Got to move that hand out of the way. And then we're going to use our pilot drill guide instrument that we talked about earlier, okay? And I'm going to go ahead and do the back implant first. It's a little bit tricky because she's got a very small mouth and this is way back there. But we're going to go ahead and try to place our first pilot hole. Okay, we got our first pilot hole made. I always like to get the back implant done first. And we set the motor to 2,000 RPMs and just drill once down and once up. Simple as that. We're going to go ahead and put our contra angle driver on the handpiece now, which is right here. And I'm going to go ahead and have Alina open up the implant. Now here's the implant in the vial. And all we do then is take the driver from the motor, the contra angle driver, and take the implant out. And we never touch the implant with our hands. We go right to the patient's mouth with the implant. At this point, I'm going to press setting number 2 on my motor, which will start the implant placement. The implant's going in right now. We've already placed the implant as far as it'll go in with a stent in place. I'm going to go ahead and remove the surgical guide now. This is getting... Open, big, and suction, please. At this point, I like to tap on the implant to verify that it's in solid bone. Every once in a while, you'll go ahead and place the implant and it'll slide off the ridge if it's a very narrow ridge. But we've got nice solid bone. We'll go ahead and put the pilot drill guide or the driver back on the implant and screw the implant down the rest of the way. As soon as your instrument touches tissue is when you stop, right about there. Okay? The first implant's in place. Now I'm going to go ahead and put my surgical stent back in the mouth. I'm going to verify that the implant is right inside the sleeve, which it is. I don't know if that can be shown or not. Let's see if you can. Whoop. Maybe you can see it. I don't know. Okay. We're going to go ahead and do the next implant. Just take that out. These Optigates don't always stay in. Now what I like to do is after each placement of each implant, I like to try the fixed restoration back in to make sure that it's still fitting in the right spot and there's been no change. So we go ahead and put this implant bridge in place and go ahead and close together. Close your mouth all the way. There you go. And the occlusion is still the same and it's still going down all the way in the patient's mouth. Okay, open. So we'll take that out. We're going to go ahead and put the surgical stent back in place. We do about 40 to 50 of these mini implants every week in my office. Hold that stent there. And if you don't believe me, you can ask Sunny. She's the one that's opening and cleaning all these cases. We're going to go ahead and do the next one. I'm going to set the motor back to number 1, which is the pilot drill. And we're working from the back forward, so the next implant I'm going to do is going to be the second one from the back. Okay, made our second hole. Our second implant is right here. Again, we're going to take the stent out. We're going to verify that we're in solid bone. I like to tap on these with the back of a mirror handle. I don't know if you can hear the tapping or not, but they're in solid bone. And we're going to go ahead and finish the placement of the implant the rest of the way. And now we have 2 implants in place. We go ahead and verify by trying the bridge back on. And it's still seating all the way to the tissue. And you can tell that by looking, of course you can check the occlusion, but you can also tell by just looking at the palatal and buccal tissue. And you'll see, is that something you can show there? Yeah. So you'll see the tissue is it's going all the way up to the, move to the left, move to your right a little, all the way up to the tissue. And the same on the buccal. So we're going to go ahead and do the next implant. What's that? Our third implant. The nice thing about this aseptical unit is it's all pre-programmed. So setting number 1 is your pilot drill. Setting number 2 is your implant start and torque test. And setting number 3 is your final placement of your implant. It takes the thinking out of it. And Lord knows that helps me. And we're going ahead and placing our third implant right now. Take the stent out. We're verifying that the implant's in bone, which it is. We're going to go ahead and place the implant the rest of the way. And again, you want to stop as soon as the instrument touches tissue. As soon as this instrument touches the soft tissue, that's when you stop, okay? We have 3 implants in place now. Go ahead and open the 4th implant. Turn your head a little that way. If you can, I don't know if you can show, but the implants are, you can see the implants right through the surgical stent. So all the implants are right inside those sleeves, as you can see the top of the balls. Okay? So I'm going to go ahead and make our last and final hole for the anterior implant. Are you having any discomfort? Good. So you can imagine it's going to be much more difficult to place these with your hands with a finger driver than it is to use a motor, because her mouth is small, it's hard to get in there. This way I just put the tip of the motor in there and I can do all of it with that. Again, our fourth implant is nice and strong, and we're going to go ahead and place that in the rest of the way. The implant goes in at 35 RPMs, and I'm hearing the audible sound of the motor telling me that we've reached 30 Newton centimeters on all of these implants. You probably can't hear that, but I'm listening to that in the back of my ear. And all these implants are in at over 30 Newton centimeters of torque, which is excellent. And that's one of the nice features of the Aseptico Shatkin motor that we have. And I'm going to go ahead and try the bridge in again. And here it is with all 4 implants in place. Did I not try it in after the third one? I may not have. Usually I try it in after each one. In any event, it's in, it's all the way seated. Bite together. Does the bite feel pretty good? Yeah. I'm going to go ahead and check the bite with some articulating paper. Bite together. Open. Bite. Open. By the way, maybe we could show the other teeth on the other side that we did not too long ago. Just a few weeks ago, we did this upper tooth here, this bicuspid, and we just did that a couple weeks ago, and you can see just how pink and healthy her tissue is. And that's the doctor who asked me about how they clean. They do very, very well. Turn this way a little bit. You see how pink and healthy that tissue is. And also on the palatal side, very pink and healthy. Now we look at the bottom tooth that we also did the same time. We did her lower close together a little bit, close. We did this lower bicuspid. Can you get to that? Want me to pull it over this way a little bit? See if we can show that. I don't know. There it is. It's down there. There it is. And that's the lower bicuspid that we did. And that again is very pink and healthy and very strong and solid. Open for me. I can tap on that very hard and there's no problem. So she's doing well with those. And we're going to go ahead and cement her upper right bridge now. Sorry to throw you off there. All right, we're going to go ahead and rinse the bridge out, and we're going to clean it. Let me just see something here. Now when I cement this, I like to use our Shatkin First Resin Cement. It's a self-cure resin cement. And the reason I like the self-cure now is because I use these lights. And I use the overhead light, and I use the camera light, and I use my light. If I use light-cured cement, it hardens up before I even get it in the patient's mouth. So I'm going to go ahead and just squirt this self-cure resin in the bridge. And I get 3 minutes of working time then. As we get older, we need more light. And I'm going to go ahead and dry the implants very, very well. And then we're going to squirt a little bit of cement right around the balls at each of those implants. And the reason for that is to get rid of any undercuts that might exist. We want to fill the undercuts so that there's no air trap or no bubbles. Then we just go ahead and cement the bridge in place. Go ahead and bite together. Open. Bite again. And just hold that together for 5 minutes. It's going to take about 5 minutes for full set. At about 90 seconds, it goes to a rubbery stage where we can start to clean off the excess cement. Have a saliva ejector. During that rubbery stage, it's very easy to pull the cement out from underneath the bridge work. But we're not there yet. So this case went pretty much as planned, very smooth, like clockwork. Everything's going very well. I don't know if we figured out how to get the, do we have the x-rays sensor working so we can take a post-op x-ray? I think somebody was coming over here from Schick to help us with that post-op x-ray. So it's about 90 seconds now, and we're going ahead and cleaning the extra cement. Go ahead and get that. Keep sucking. Now keep in mind, you don't want to be pulling on the bridge at this point because the cement is not fully set. All I'm doing is cleaning off the excess cement. Open for me. Okay, go ahead and bite again. And we'll have you keep biting for another few minutes, okay? We know how to do it. If we can't do it, it's okay. And again, you see there's no bleeding, there's no swelling, there's no redness. It's a very simple procedure. The patients are very, very happy, and they can go home and they can eat that same evening. In fact, I'm going to take her and her daughter out to dinner later and feed them something good here in New York. Open. And we'll have about 12 or 13 witnesses to let us know if she's in pain or not. Right, Rodney? I'm flossing now in the front and in the back. We got the majority of the cement. I believe we've got all that out now. Nice and strong. We'll go ahead and check the bite. Go ahead and close together. Open. And you can see there's a slight interference on the lingual cusp of number 3. So I'm going to do a little bit of occlusal adjustment, but very, very minimal adjustment is going to be needed here. The water running here. DJ, is the water running?
Should it work?
Well, this is working, but this one's not. All right, just drip a little bit of water for me, okay? Just don't want to heat the porcelain up too much. So I'm just rounding off that one lingual cusp. We'll check the bite again. Bite again. Bite again. Hold it. Open. Just a little bit more there. Bite. And that's all better now. Bite again. Open. And bite again. Bite and hold it. Hold it together. Open. Bite tight and hold it. Okay. Bite. Open. Bite. Open. Good. Very good. So we've got it in very light occlusion. We don't want it in heavy occlusion, but we don't want it in light occlusion either. So thank you very much, Vera. You did very well. That's why they call you Vera. Yeah, I'm going to sit you up if I can. Okay, so my assistants will get the rooms cleaned up and ready for the next patient. Be careful getting out because it's a little high. 1 second. Let me lower the chair. There we go. Okay? Thank you very much. Okay. Yeah. Come on out. All right. Any questions from anybody that wants to ask? If you have any questions, come on up to the microphone, or Juliet will bring the microphone back to you. And we're going to give her a water pick to take home with her to keep it clean. We're going to have her back in our office on Monday or Tuesday. We'll educate her on proper hygiene. We're going to go through the floss threaders and all the stuff that she needs to keep her mouth clean. Yes, sir.
Do you use a lingualized occlusion like you would use in a standard implant case?
I keep it in a cusp tip occlusion. I don't do anything special, lingualized or otherwise. Julia, take the microphone. We try to put them into a group function if at all possible, but we don't do anything special like lingualized occlusion. I did reduce that lingual cusp. It was hitting premature, and now she's got very light occlusion all throughout. But she can chew on that. Yes. What's that?
You brought ice packs. Do you want to give her one?
Oh, she doesn't need an ice pack.
Okay.
They get almost no swelling with this procedure. Yeah.
Are there square bases under the balls, and if so, do you have to align them to the pre-made crowns?
Right. So there are square bases under the ball, but the holes in the crowns are slightly bigger, so the implant can be turned any way it needs, and the crown will still fit. Okay. Yes.
I wanted to ask a question about lower mandibulars. Suppose you have a knife-edged bony ridge or very, very little bone there, a lot of recession. How do you handle that?
Yeah, so when you have, we all run into this, right? We have very, very short ridges or we have very knife-edge ridges. If the ridge is extremely knife-edge, now we're going to be doing a case next where there is a very thin ridge in the maxilla, same idea. It's almost like a knife edge, but not quite. If I need to, I will drill my pilot hole with a high-speed diamond, a very thin diamond, and get the hole started that way as opposed to using the slow-speed pilot drill. And that will help engage that thin knife edge ridge. Sometimes, but rarely, do I need to make a flap and open the gum tissue and flatten the top of the ridge. But very rarely, okay? Very rarely.
Yes. Yesterday they had a surgeon.
Where are we? Okay.
Yesterday here they had a surgeon that was loading an implant. He said he wouldn't load it unless he had at least 50 to 60 Newton centimeters squared. You loaded it with 35.
The minimum is 30 Newton centimeters to load it, but that means we had more than 30. The minimum was 30. I pushed the button up to 60, and it was torquing in at 60 Newton centimeters at the end. So these implants are in there probably somewhere between 50 and 60, but I will load an implant at 30 minimum, but I like to have more. Obviously, the more you have, the better, up to a point. If you get up to a point where it's 70 or 75, what does that indicate?
You've got good bone.
There's a lot of bone, but there's not much blood supply. And so you want to have some medullary blood supply too. So you don't want it to be so dense that it's all bone and no blood supply, right? So the best is somewhere between 50 and 70. If you get over 70, even though we can torque these implants in up to 75, 78, that can be a problem because you can cause bone necrosis if you're not careful.
Does the drill indicate if it does not reach that level? Will it tell you?
It will. It'll beep when it does reach a level. If it doesn't beep, then you haven't reached that level. And you can set the drill to whatever settings you want. We set it to 30 and then to 60.
All right. Thank you.
Yep. Any other questions?
I just wanted to point out that I actually took Gordon Christensen's course yesterday, and he is a very big proponent of the mini implants, but in his course he only discusses removable appliances, not any fixed bridge work.
Yeah, let me tell you a little quick story, and then I'm going to have Tom come up. But several years ago, I went out to Utah and visited with Gordon and sat in his little office, and it was kind of a funny story. I called and I asked if I could come. I called the secretary and asked if I could come out and visit with Gordon. This is before I had a personal relationship with him, and I'd like to show him some cases. We're talking about 8 or 9 years ago, and they said, "Okay, I'll get back to you. I'll talk to Dr. Christensen. I'll get back to you." Well, a couple weeks went by, nobody called me, so I was persistent. I called again. I said, "Would it be at all possible for me to come out and visit with him? I want to show him some of the things I'm doing with mini implants." And they said, "Well, I talked to Dr. Christensen. He's got 15 minutes for you on February 14th. That's Valentine's Day, right? So she said, "Be here at 4:30 on February 14th, and he'll take care of you." I said, "You know, I'm flying all the way across the country from Buffalo. Do you think I could get 20 or 30 minutes with him?" And she said, "Well, I can only pencil you in for 15, but let's see what happens." So I flew out to Utah, and I brought my friend. I said, "If we're going to go out there for 15 minutes, we may as well make a ski weekend out of it." So I went out and we skied, and then we went and I visited Gordon Christensen. And I was looking at my watch the whole time thinking, "Hey, boy, I got to speak really fast and show him these things really fast because I got to get out of here in 15 minutes. And I was a little nervous. I was more nervous then, trust me, than I was in front of all 500 of you. Okay? We sat down, and I started showing him some of the dentures and then some of the fixed crowns that I was doing on mini implants. And he said, "Todd, give me a minute, I'll be right back." And he left the room. I thought I was going to be escorted out at that point. But he came back in with his laptop, and he started showing me the cases he was doing with mini implants. And guess what? A lot of fixed crowns, a lot of laterals, a lot of bicuspids, anterior teeth, molars. I said, "Why don't you ever talk about it?" He said, "Shh, don't tell anyone." He doesn't want to tell everyone, but he believes in them. He uses them, and he talked to me about it in Buffalo. He showed cases that he did in our course in Buffalo for the last couple years. And if you ask him, he'll tell you he does some fixed on them, and he will tell you to come talk to me if you want to do the fixed on them because he knows we've got the research. We actually have higher success rate with fixed, 98%, than we do with removable, which is about 93%. The fixed success rate is unbelievable. There's no micro movement. The implants last and they work really well. Another question.
Thank you very much for your lecture. It's very educational.
We have a doctor here that came all the way from Nigeria. Let's give him a round of applause. Thank you.
Thank you very much. Actually, I live in Washington, D.C.
Oh, okay. Well, didn't you have a tag this in Nigeria?
Nigerian accent.
Oh. All right.
Listen.
Well, we did have 2 other doctors that came to my booth from Nigeria. I thought you were one of them, but I guess the light's a little bright. I apologize.
Okay. This is my question to you.
Yes.
Your pilot drill is way smaller than the implant.
Yes.
How do you prevent tracking soft tissue into your, along the thread
Yes.
of the implants when you place them?
Thank you. Yes, so what we do, and you have a choice, you can use a hole punch if you want to, and in our kit, and I apologize for mixing you up with another doctor, but we have a hole punch in the kit if you want to use it. But I personally don't like to use the hole punch. What I do is I puncture through the soft tissue with the drill before I start the spinning motion. I push it through, and I palpate the ridge with the top of the drill. And then I start the drill and go through. And I believe that prevents the soft tissue from going in. I can tell you I've been doing it the same way for 14 years, and if we were getting a lot of soft tissue in there, I think we'd have more failures. So we don't seem to be having a problem with that. So we puncture through the tissue, and then we start the pilot drill. Any other questions? All the way over there. Go run, Juliet, run.
I'd just like to sing Fly Me to the Moon first. Now, Doctor,
Go ahead.
Excellent presentations. Thank you very much. But if you're not reaching 30 Newton centimeters and you feel it's going in too easily, would you just leave it and hope for it to osseointegrate later on?
You have 2 choices at that point. Let's say we reach 20 Newton centimeters, but not 30. You can choose to leave it, maybe temporize with a healing cap and leave it totally out of occlusion for a month or 6 weeks. Or what I choose to do normally is reverse it, take it out, and go 1 size larger in diameter. So if I'm using a 2.0, I'll go up to a 2.5. If I'm using a 2.5, I'll go up to a 3.0. And what that does is it compresses more bone and you get more torque resistance and more surface area. And almost every time you go up to that next size, you'll get the 30 Newton centimeters of torque.
Thank you.
But if the ridge is too narrow and you can't go up to that size, I think you bury it, you leave it there, put a temporary cap on, leave it out of occlusion, and wait 6 weeks to let it osseointegrate. Yeah.
Great presentation. One quick question. When you were with Dr. Christensen, did you only last 15 minutes that first visit?
So let me tell you the rest of the story. That's a good question. I'm glad you asked. Actually, he started showing me his cases, and the whole time I was really like looking at my watch, and we ended up talking for an hour and a half. And finally, his office administrator came in and said, "Gordon, your wife is getting really angry. You got to go." It was Valentine's Day, and they had a dinner date planned. And so he said, "Oh my gosh, I forgot. Okay, I got to go." So that's how we left it. But after that, we became friends, colleagues. He's a wonderful guy, and he genuinely believes that every general dentist should be doing these mini implants. Yeah. Any other questions before we start the next case?
Yeah, do you ever decide to do an incision and make a flap? Go use the bone in order to avoid the soft tissue going into the socket?
I don't worry about the soft tissue going in the site. It's not an issue. I do raise a flap occasionally if I have a very thin ridge or if I can't find the bone with the pilot drill. Then I don't do a big flap. I'll usually make an incision, just tease the tissue apart so I can visualize it. But I rarely do that, rarely, okay? All right, so Tom, I'm gonna have you speak for just a few minutes. I'm gonna get my next patient up here in just a second, and we're gonna get things started. And Juliet, you should be the one singing Fly Me to the Moon. You're the singer. All right, come on up.
I gotta talk.
You gotta talk at the podium, okay?
Well, thank you very much, everybody, for listening to Dr. Shatkin. I have the good fortune of spending quite a bit of time with him every week. And I want to tell you that not only is he a good friend of mine and my boss, and I have to say nice things about him, but he has helped many, many, many patients out. I've traveled to Australia, Singapore, Paris. You and I climbed up the Eiffel Tower. We did. We climbed up all the steps. We did. London. We've been all around the world placing mini dental implants and teaching doctors how to help their patients. Dubai. In June, we were in Dubai, and he spoke at the Asian Pacific Dental Congress. So we're on this quest to help many, many dentists to help their patients place mini dental implants. And today Juliet's going to help me. She's going to be my Carol Merrill, and I'm going to explain to you what we're going to offer. And I see a lot of familiar faces in the crowd, too, who've been up to our course in Buffalo. What Dr. Shatkin offers that no other company in America offers is, first, he will review every single case that you send in to him. I watch him early in the morning, and I watch him late at night. He's going to work on every one of your cases. You send us a polyvinyl impression, you send us a good bite, a good polyvinyl impression, a good bite, and either a panoramic x-ray or a CT cone beam, and he will review the case, and we'll send you back a CT guided stent. You can, if that's what you prefer, we'll send you the implants you need for the case, and we'll send you everything you need for that particular patient in one lab box. And we prefer to work on a case-by-case basis with you, okay? Today, Juliet's holding the starter kit. This starter kit that we put together, we sell this kit for $19.95. There's 12 implants in it, the instrumentation kit, and we give you 4 of the pilot drills that Dr. Shatkin used because they are disposable. And please don't try to autoclave them. And we will give you the pilot drill guides that fit into the titanium sleeve of the guide stent. You get the surgical ratchet wrench, the instrumentation, the hard resin cement, the self-cure resin cement, and we give you a variety of sizes of implants. You can return any of these implants at any time as long as they're sterile to exchange sizes, okay? But we wanted to give you a variety of implants. They come in 10, 11.5, 13, 15, and 18. So this kit we sell for $19.95. Thank you, Juliet. This kit here is our essentials kit.
I need a.
Instead of giving you.
Just, do you have any of that? Scalpel? Yeah, scalpel blade, just in case.
Hard to hold, isn't it? Okay. So instead of giving you 12 implants, we're going to give you 16 implants. And we're going to give you some patient education DVDs. We're going to give you a marketing CD, which, by the way, we have a big marketing department back at our headquarters in Buffalo that once doctors agree to start placing the mini implants and helping their patients, we'll help you to market. And Mark Aarons happens to be with us today. He's going to help every one of you with a great creative team to help you to let people know in your geographic area that you can place mini dental implants, and you're doing it. We also have a technique DVD, Dr. Shatkin's patented technique DVD. We're going to give you, it's Dr. Chris Kammer out of Kansas doing a mini dental implant. So we're going to give you the instrumentation kit again. We're going to give you both the blue pilot drill guide and the silver pilot drill guide. Okay. We're going to give you all the instrumentation. And we're also going to give you some of our one-piece implants that has the abutment head built in. And we're going to give you the one-piece contra-angle driver and the one-piece ratchet driver that fit over the abutment head. We're also going to give you some lab components. We're going to give you some, oh, speaking of the lab, where's Valdi? Valdemar, are you in the house? He was supposed to be here. Is he over there? To my left. Okay, step.
To the left, to the left.
Come on over a little bit, Valdi, come on up. Valdemar Blazak has done more restorations on mini dental implants in his lab. He has about 55 technicians up there. They've done more mini dental implant restorations than any other lab in the world. And Dr. Shatkin and Valdi have been together since 2003, if I'm not mistaken. So he will help you. He'll guide you. The way that Dr. Shatkin stands with you step by step, Valdi will do it on the lab end. So we're going to be with you, okay? And we're going to give you some lab components. Here are the one pieces. I know we have to move at a pretty good pace here, and I'm taking too much time. But most importantly, we have these models. Thanks, pal. These models here, when Dr. Gordon Christensen was lecturing with us in Buffalo in July, he really thinks it's important to have these models. When I watch Dr. Shatkin talk to the patient about the mini implant case, he always puts the models in the patient's hands. You get an upper denture model, a lower denture model, and a crown and bridge model. And having that in the patient's hand, when they see a small diameter implant, they don't get intimidated, and they're more accepting of the procedure. So think about having the models. You can talk about them till you're blue in the face, but putting the models in their hand and showing them what a small diameter implant is, it really puts them at ease. We give you 100 patient education brochures for your office, and then we give you a hard reline kit. So, and resin cement, and of course we give you some bone grafting material, which is called Rios Bone Putty. This is from the Interlock Corporation. It's a biosynthetic product. We have doctors that call and order 15 bottles. It's a half cc. It's like a ball of putty that you can pack in the extraction sites. They order 15 bottles at a time. This stuff is amazing. It's 3 to 4 years ahead of any other bone grafting material on the market today. So this kit, well, one thing I didn't mention is anybody who starts with our company, we give you 6 months to find a patient. If you don't find a patient, I'm going to walk into Dr. Shatkin's office, and I'm going to ask him to write you a check for either $39.95 or $19.95. We will pay you back if you send us the kit back. Since 2003, we've had 2 kits come back. And the reason we wrote a check to that doctor was because he could not practice anymore due to health-related issues. So start with our company. I think you'll have great success. If you follow our steps, we try to dumb it down and make it as easy as possible for you. So stick with us, and we'll help you to A, have happy patients, and B, make revenue for your business. The third thing I want to tell you, do you remember, and this is a good analogy, do you remember in the 60s and 70s when Sony made Trinitron cathode ray tube TVs? You got this? I used to lift them. They were 375 pounds, and they were this deep. Today, Sony makes with new technology, Sony makes a television that's about that deep. And the picture quality is phenomenal. They call it 4D high definition. Technology improves over time, and things get smaller. Conventional implants are absolutely phenomenal. But I want to tell you that so are small diameter implants. They're smaller, and they work. And I want to be up on the stage today if I didn't believe in them, and I believe what we're doing as a company. Really? So please follow Shatkin First into the future, and we'll guide you to make mini dental implants an integral part of your business and your success. So thank you for the time. I appreciate it. And come back to our booth 1417, and we're going to be there all night tonight until they kick us out. What's that? Yeah, right. Visit our website at shatkinfirst.com and visit our app as well.
Tom, I just wanted to mention we have this sheet that Mark gave out to everybody. If you fill that out and just drop it off at the booth tonight or tomorrow morning, we'd love to have you do that and then come to Buffalo for a free seminar. So I look forward to seeing you all there. We're getting ready for the next case now. This one's obviously a more challenging case. I'm doing 8 implants. Thank you, Tom, for doing a great job. Appreciate it. We're doing 8 mini implants. It's a very thin ridge, so I'm going to be using the 2mm implants because of the ridge is so thin on the upper. And we're putting 8 implants in, and we're doing what's called fix on 6. And we use 6 to 8 implants typically. If I get 6, 7, or 8 in there, I'll be happy. Our goal is to put 8 in, but if we end up with 6 or 7, that's fine too. I always like to do a little more. It's always better to have more, and then if you end up with less, it's okay. This is a challenging case, and because of that, I'm prepared both with a final restoration and with a temporary roundhouse restoration, just in case something doesn't go exactly right and we have to adjust it and fit it. We can use the temporary, okay? And our patient James is aware of that. We've talked about it. I'm pretty confident we'll get him finished with the final zirconia with layered beautiful porcelain on it. Now, you're all familiar with All-on-4. That procedure typically costs anywhere in the range of $35,000 to $40,000 to complete. There's all kinds of clinics out there, as we know, the Clear Choice clinics, and then a lot of you probably provide All-on-4 services. This procedure is less than half of that cost. I typically charge in my office, actually it's about a third, I charge $12,500 for this procedure with 8 implants and a final restoration. You can't beat that for a fixed type restoration. Now, patient doesn't take this out, but you can take it out every 6 months or 4 months, whatever you like. So we're going to go ahead and get started here. What time is it? Okay, we got to move. So we're a little bit behind schedule, but we're going to try to move along here. How you doing, James? Good? James, you've had your denture, you said, about 26 years. Yeah. What don't you like about it?
They're annoying.
They're annoying, he says. What's annoying about them? They come loose. He's got to use the denture glue. In fact, he came in here with a bunch of denture glue in his denture, and he doesn't like that very much. Let's sit him up a little here. I got to get him situated where I want him here. Now, Dr. Rodney Leibowitz in Brooklyn is your dentist, and he's like I said before, he's a very good friend of mine, and he was very kind enough to help get this case to where it is today, doing the try-ins, doing the fittings and whatnot, so that we can go ahead and do this case today for us. And I appreciate that very much, Dr. Rodney. And I appreciate you, James, very much for volunteering to be a patient here. And I didn't thank the Greater New York Dental Society for inviting me to speak as much as I should have, but I'm very, very flattered, and I appreciate it very much to you all as well and the committee that put this together. I'm going to go ahead and lower it just a little bit. Let's see if, I don't know why it's not going. Let's lay him back, and then we'll raise it up. That should be good. Okay. So I've never examined him yet. Okay? It's my first examination of him, and he's got quite a flappy ridge, very thin ridge. And Rodney promised me this case would work fine, so we're going to make it work. But it's a tough one. You can see that ridge, the flappy tissue moving around. We're going to go ahead and get him numb first. And there's a possibility we may need to use the high speed to make my pilot holes like I mentioned earlier, but we'll see about that. We'll go ahead and get you numb, okay? We'll use the wand again to numb you up. Well, we got some more to give him. I'm sorry. That front one is a pinch. I apologize. A little bit on the other side now. I know those ones in the front sting. I'm sorry. Try to stay so. Okay, that should do it. That's the worst part. Let's rinse him out a little bit. Okay, so like I mentioned, we had a temporary roundhouse bridge made right here. That's an acrylic bioform temp. Bite together for me. And that's, his occlusion is real good. His aesthetics are very nice. Open for me. And we also had the porcelain, final porcelain zirconia bridge made here, which obviously looks a little more aesthetic, but they both look very nice. Go ahead and close. And again, here's the final bridge in his mouth. And he's already approved these. He's opened for me. He's been to Dr. Leibowitz's office. He's had these tried in, and he likes the way they look. So we also had a surgical guide stent made. And we're going to go ahead and make our placement of our implants. Now, I'm going to start again from the posterior. The anterior ridge is very flabby and very thin. It's a difficult case, and had I been bringing this patient from Buffalo, I probably would have found someone with a wider ridge. Thanks, Rodney, for challenging me today. I appreciate that. But we're going to make this work. And I'm going to go ahead and you hold that still on your side, okay? Where is Rodney? Is he here? Sure, he escapes right during the tough part of the day. Where'd you go, Rodney? All right. Don't worry, James. We're going to be fine. Don't you worry about a thing. I've actually done this before. So, all right, we want to make sure the surgical guide is very stable, and we're going to go ahead and start from the back right side. All right? Let me know if anything bothers you at all, okay? Okay. Hold that real still. It's very important to keep the stent in the right place because we got to place that implant now. And now we're using the 2.0 by 11 implants here. You know, we go ahead and place that one. Okay. And we got it part way in, and now we're going to go ahead and place it the rest of the way. I always feel the buccal and the lingual to make sure that we haven't perforated, especially on these very narrow ridges. And what I'm going to do now, which I usually do and forgot to do, is I'm going to mark those locations with a marking stick for the rest of these so I can see exactly where we're going and check and verify the position. So that's where the plan is to place the remaining 7 implants. Okay? And I like the plan. I like the position. You can see this ridge here is very flabby, but we're going to try to grab onto some bone in there. I'll darken them up a little bit with a marking stick, a marking pen. And actually, the surgical guide stent actually holds that flabby tissue still, and it makes it actually easier to drill than it did. There's Rodney. He finally showed up, Rodney. Did you hear what I was saying before? You gave me a challenge here. Flabby ridge, knife edge. We got one implant in already, though, so we're 1/8 of the way there. All right. Where's the drill guide? Okay. We're going to go ahead and put the pilot drill. I'm going to go ahead and do the opposite side now and stabilize the surgical stent. So we'll do one on each side and get that stent stabilized. Rodney, you're buying me a drink later after this one. Okay, move your hand. All right. I'm definitely not a drinker, but I'm going to probably need one tonight. All right, we're going to go ahead and take that out. And we have the second implant, and we're testing it. It's in solid bone. I'm going to go ahead and place that implant the rest of the way in. Okay, we got two out of 8 in place. Go ahead and put the stent back in. I'm working my way up to the harder ones. Starting in the back where it's a little bit wider ridge. Funny, my daughter's here telling me I'm doing great, Dad. And I remember telling her those things when she was growing up. The roles are reversed now. Section that. This one's a little wiggly here. That one did not catch the ridge. So I'm going to take that implant out. So the other reason we make those marks is so that we can see where the marks are in case we have to go in without the stent to find the bone. And that's what I'm doing right here. Because of that very thin and knife edge ridge, I'm going to try to drill this freehand here. We'll go ahead and try to place that implant back in the same location where we made the mark. Now the big question is, will the surgical stent line back up in that location? And let me see the mirror. Looks like it's pretty close. Okay. So we're still okay. We're still okay. I'm going to go ahead and do the other side. Okay, we got that hole made. Do you have another implant for me, Juliet? You sure it's okay that you're missing your voice lesson, Juliet? Okay, I've got 4 implants in so far. Phew. All right, we're going to try this restoration in now and just see how that all lines up. Go ahead and close together. That's lining up very nice so far. Open. Of course, we have to put the housings in there and fit the housings over it, but we'll do that after we're done. All right, go ahead and let me put the surgical guide back in place. It's going to get tougher as we go around the front. But if I can get 6 in, like I said, if I get 6 at least, I'm going to be happy. Anything more than that is a bonus for us. I'll go ahead and try this one here. Oh no. I don't know if that caught the bone. Let's see here. It's extremely thin there, and my drill's just sliding off the ridge. So what I'm going to do is I'm going to take my high-speed diamond, like we mentioned before, on a high-speed handpiece. And I'm going to go ahead and try to make my hole with that. A little suction here. A little bit of water. Okay. Now because of the thinness of that ridge, I'm going to go ahead and try to place this one by hand just to get it started. Okay. We thought we had it here. Nope. Okay. I'm going to bypass that one for now. And we'll go to the next implant. And maybe we'll come back to that. When I was a kid, my dad taught me that if you're in an exam and you have 50 questions, don't get hung up on one of them. Skip that one and move to the next one, because you may never get done if you stick with it. So let's go to the next implant. We'll try to come back to that one later. All right. So at this point, I'm just kind of using the surgical stent for the markings and the locations, and I'm just kind of hand placing them just because of the thinness of that ridge. And we're going to go ahead and do the next one now. So we got 5 in now. I'm getting closer to my goal. Right? 5 out of 8. Show that a little bit. That felt like we got good bone though. So let's put that next one in. All right, James, we got 6 implants in place, okay? We're going to go for our 7th one now. Let me stop here and let's try the bridge in place and see how that goes. Go ahead and bite together. That looks good. Open. We're going to have to make sure the housings fit over that, but that'll be the last thing we do. Okay, these last 2 are the hardest ones right over here. Tell you what I'm going to do here. These last 2 are tough. I'm going to make a small incision, and we're going to open up the gum and visualize the bone there. Before I do that, I know you felt a tiny bit over there. I'm going to just give you a tiny bit more local. Right where we're working here. You okay? No pain? Okay. So we got 6 out of 8 in without an incision, but we're going to go ahead and this one little area where the ridge is very, very thin. We have sutures too, right? Well, check in the box right there. See if there's a box of sutures. Do you have some sutures in the box, Tom, right there? No? They're not in there. All right, Go grab me some sutures. I don't know if they have them up here. Do you guys have sutures here? No? I got it. Let me have it. It's stuck. Stuck shut. Yeah. Got jammed shut.
Oh, it's here, it's here.
No, no, it's not.
So
It's,
that knife got stuck in
it's not that, though. I don't think it's the front. Suction right here. Well, you can see how thin that ridge is. Talk about knife edge, it's extremely knife edge. And that's why we couldn't drill through it. However, we're going to make it work. You didn't bring a round chair, did you? Okay, hold that for me. I need an implant. So I'm going to go ahead and place this implant in that hole there that I made. I'm going to do it with a finger driver to get it started. Okay, now I'm going to go ahead and take the motor to finish it off. Hold that. Okay, we got that implant in place. I'm going to go a little bit deeper. All right, we have 7 implants in place. I can't wait for Roddy to ask me to line up a patient for him. Do you have another fine diamond?
Yeah, I do.
Where would I find it? Number 12. Let me see.
Yeah, I know, I'm looking. Hold on. 25, 14, 23.
Just bring him over here.
Wait. This is it.
Yes. All right, we got 2 types of sutures. We'll take the ones in here. Thank you very much for going to get those. All right, let's try to put the last one in if we can. Retract that with the, can you retract that with the elevator here? Well, can you all see that knife edge ridge there? How flat, how pointed that is? I'm going to flatten it a tiny bit with the burr. Take off that very flat tip of the bone. And then I'm going to go ahead and let that go for a second. Let's see where that mark was, because we've got to come close to the mark. If I can see it. I think we tried to go right about here. And go ahead and okay. Go ahead and give me the next implant. It's the wrong one. 2.0 by 11. No, they're not. Last one was a 2511. The other one was a 2511. See? It was a 2011. That one's a little tricky there. That ridge is very, very thin. When at first you fail, try and try again. Let's give it one more shot here. Hold that. Hold that. Okay. The moment of truth. Okay. Well, we got all 8 implants in. Patient's happy. The only issue we have here is that one implant, not this one, but the one prior to this, was angled a little bit facially because I had to angle it to find the bone. So I'm going to go ahead and try the bridge on, but I'm pretty sure we're going to have to do some adjustment there to get that implant into the area where we want it to be. Let me have a mirror, please. Not sure if it's going down. Go ahead and close together. The bridge still seats over the implants now because the holes are very big for the housings, but open. But we're going to go ahead and put the housings on now and try it. I think I'm going to have to bend this one implant a little bit. Well, we'll see. So let's go ahead and put the housings. So we're just snapping the housings on. And I will suture that gum tissue at some point here. I just want to get these. Now this is a fixed detachable bridge because it's removable by the dentist with the housings. Oh, that one implant there. It's detachable by the dentist, not necessarily by the patient. But as you can see, this one implant right here is angled more forward than the others because of the way the bone was. I don't think the bridge is going to go over that, but I'm going to give it a whirl. Yeah. So it's close, but that one implant is holding it up, I believe. So what I'm going to do is I'm going to go ahead and show you now how we bend an implant once it's placed in the patient's mouth. Of course, we have to be very careful here because we had an extremely thin ridge to begin with. So we go ahead and put the ratchet wrench driver over the implant. We grab the buccal and lingual plates. And we bend the implant into the right angle. And it's still nice and solid. Now, let's try the restoration on. How's the mirror? Bite together. Open. Now we get the restoration all the way in. Very nice, very nice. Well, now we're going to put a couple sutures in there. Actually, I think I'll wait till I pick up the housings because I'm afraid we'll lock the cement on the suture. So let's go ahead and do the pickup. But before I do that, there's a couple implants. I'm just going to screw them down a tiny bit further. We got plenty of space. I'm going to go in a couple more turns with a ratchet on these. Plenty of space for the housings. Not going to do that one. That's the one I bent. Not going to do that one. I'm going to just screw this one down a tiny bit more. What time is it? Okay. Well, I apologize. We're running a few minutes behind schedule, but we're going to be done here very soon. Just rinsing out the bridge and drying it. At the same time, Sonny's going to dry the patient's implants. I'm going to take our resin cement, our Shatkin First self-cure resin cement like we used before, but this time I'm going to use it to pick up the housings in the bridge. So I'm going to fill that up. And now we're just going to go ahead and seat this over the implants. Bite together for me. Now, I'm not suggesting you go home and try this type of case your first time around. But you certainly can replace one or two missing teeth. You can do an overdenture. Who's the young lady in the front row? What's your name again? Diane? Diana? Stand up for a second. I'm not trying to embarrass you, but Diana came to our lecture last month or 2 months? September. And you did your first case how long ago? October 25th, she did her first case. And what was it? Was it a tooth? Number 3 and number 12. And we made you stents. We made you crowns. You put the implants in. It went smooth. Let's hear it for Diana. Where do you practice, Diana? Union City, not far from here. Thank you very much for telling me that story. So all it takes is coming to a lecture, spending a little time with us, learning how to do this, and you can do it too. And if you ever have a problem, your saliva, you just come to Buffalo and we give you some hands-on training. You can look over my shoulder. You can spend some time in my office with me, and we'll help you get through any problems you have. You just have to believe. Believe in yourself and believe in minis. Be a believer. Oh yeah, you have to buy the starter kit too. Rodney, I'm done harassing you. Thank you for bringing me a wonderful patient and a great case that worked out very nicely. Let's hear it for Rodney. I know you'll get me back later. Open up for me. Cement's still hardening up. I'm not going to take it out just yet. Just taking off all the excess flash that's around the outside. Nice thing about this cement, it really doesn't attach to the polished surface of the porcelain. It only attaches to the underside that's not polished to the holes. So it's very easy to clean up after you're done with it. Guess what? You're getting your permanent teeth. I wasn't sure for a while there, but you're getting your permanent teeth. All right? Keep biting for another few minutes just to make sure it gets real hard. We have any other questions about anything here, about this case? Yeah. Go ahead. Can I what? Oh, I'm going to take it out. I'm going to let the cement harden a couple more minutes. Then we're going to take it out. We're going to clean all the flash off and then put it in.
And why do you think the patient cannot do that?
Why can't they take it out? Yeah. They could. Yes. Okay. But I tell them not to.
And why not?
Well, because I don't want them to drop it and break the zirconia bridge on the floor. And I would rather they leave it in because it's a fixed bridge and it's cleansable the way it is. They can come in every 2 months, every 3 months for removal and cleaning if you want. But my experience is every 4 to 6 months is just fine. If you want them to take it out, it's fine. But I get nervous, if they drop it and break it. A denture can be repaired easily. A $12,000 bridge is something different. You know what I mean? So any other questions? Yeah, right here, Diana.
When you were bending the implant,
yes.
How do you know how much pressure?
Experience.
Okay.
You've got to know how much to do. But the most important thing is to hold the buccal and lingual of the bone while you're doing it, and then just bend it so that you put enough pressure to bend it, and then you only do it once. You don't want to bend it back and forth. Just one bend, and that's it. All right? Yeah. Question in the back left of the room there. I'm going to go ahead and try to remove this now.
Thank you. When you have patients such as this with that much flabby ridge and you're already in there with an incision to locate it, you ever do tissue adjustment or tissue reduction?
We certainly could have done a tissue reduction. We could have done a laser gingivoplasty on this case if we wanted to. Had I met the patient prior to this, I may have done so. But obviously this is my first visit with him. But yeah, the flabby tissue makes it tough. Makes it a little tough to do. And so that's why I had to make an incision. You have a football diamond right here?
When would you not do a mini implant? Are there cases that would not be good for this?
Almost never would I not do them. I do them on almost any patient that can have an implant, but I don't know why I got these in the wrong holes, I think. But, you know, there are certainly cases where they're just not candidates for implants if they have no bone at all, if they have very poor bone, if they have a lot of autoimmune problems and are on a whole list of medications and the chance of success is minimal, we would probably do something different.
Doctor, what is the limiting factor that keeps the implant from going deeper than you want it to go? Is there a collar on there that?
Yes, there's a polished collar, and we stop the implant as soon as the polished collar is flush with the tissue.
The tissue or the bone?
No, the polished collar is flush. The top of the collar would be flush with the tissue. The bottom of the collar should be pretty close to the bone, and the thread should be in bone. But the top of the collar is flush with the top of the tissue.
So if you have that, flabby tissue there, are you not as deep as you want to be, or you just compress it, or?
Well, there is probably, in his case, there's a few threads exposed inside the tissue, but that's not the end of the world.
Mm-hmm.
It's not the end of the world.
Okay.
In fact, the early mini implants didn't have any polished collar. They were all threads, and it wasn't a big deal.
Also, one more question. I understand that there's no nerve endings in bone, so is it necessary to numb up the bone or just the gingiva around it?
Well, we anesthetize the tissue, and it infiltrates, and it does go into the bone. But you're right, which is why we don't have to give a nerve block in most cases on the lower jaw, because there really is very little nerve tissue inside the bone itself.
I've seen doctors place those mini implants without any and it's no mandibular
No anesthesia at all?
No, just around the gingiva.
Yeah, just the gingiva. That's usually what we do. For a lower anterior case, we simply infiltrate a little bit on the crest and on the gingiva.
No mandibular block.
Right, we never give a block. I'm just cleaning off a little bit of the flash. I don't have a lab engine with an acrylic burr here, so I'm kind of just doing it with a high speed to polish it. Any other questions?
I am born in Macedonia. I graduated in Pittsburgh, and 3 times I went all around the planet. This kind of doctor doesn't exist. He is #1 in all planet. Congratulations.
You're very kind, but I don't know about that. But thank you. You're very kind. Okay. Other questions? Anybody? I'm almost done. I'm almost done. I'm almost done. I can't help it. We didn't have the right stuff. Yes.
We're over time. Yeah, there's.
Give him a microphone. They can't hear you, Rodney.
Where is it?
Oh, I wanted to show this to everybody. Yeah, I don't even think we need a suture. We're going to take this out. Rodney will take this out in a few days. That tissue's adapting very nicely. Just going to leave that, and it'll heal over.
I legitimately started these 2.5 years ago, and
let me just, Rodney, hang on a second. Let me just show. So this is the final restoration with the 8 implant housings in place. When he comes to your office, Rodney, take it out and just do a little adjustment and polish the underneath side, because I don't have any pumice here or anything, but just clean that up a little bit and polish it, okay? All right, go ahead. You can keep talking.
I started this 2.5 years ago. I went to a teaser course. It was a 2-hour course in Queens. And I was looking for something for a patient of mine who went for conventional implants. She had bone augmentation done after she lost all her teeth. The implants were ordered. The surgeon opened her up. I had an oral surgeon in my office at the time. And her arch was, as he put it, eggshell-like. And he couldn't put any implants. And he closed her up. And I had promised this young lady that we would get her into implants after she lost all her teeth. and he told her that you can't have implants. And she grabbed my hand and said, Rodney, find something. And that's when I heard about this course, and I really legitimately just went, and I was hoping and praying. And I went there for 2 hours. And after 2 hours, I felt like you. This guy's from heaven. He's so good. He knows what he's talking about. I ended up buying the whole kit while I was there. I called her up on the way home. I did the case probably about, I seated it. I went to a full 2-day course the following week. I seated the case legitimately 3.5 weeks later. So my first case I ever did with minis or any implants was a full roundhouse. And the patient, 2.5 years later, is really happy. And all I can tell you, the guy is really as genuine as he seems, and people may not think it, but he really is. And when you start working with this group, they really support you. And some of the other people that might be here will tell you, people help me, I help others. He creates this a fraternity or a sorority without that nonsense you hear about that's going on. And I just want to say, the guy really is a gift to us. And thank you very much, Todd.
Thank you, Rodney. Thank you so much. And thank you all for being here. I know we're a little late. I apologize to the society. And thank you, Leonard.
All right, Todd, thank you. Ladies and gentlemen, one more time for Todd Shatkin and his patient and his assistant, his staff. Only in New York. As a
How
matter of
about
fact,
for my patient?
look at this guy. He sat through the whole thing. By the way, we have 7 minutes left, and I'm going to pull one person out of the audience that's going to come up here. It's so easy to do, and they're going to be able to do it on another patient in 7 minutes. How do you think about it? No?
Only
Not
on a
tonight?
lateral.
Anyway, thanks so much, Todd. Only in New York, ladies and gentlemen. This is what we have at our speakers. Again, don't forget to visit your exhibitors. Todd Shatkin, booth 1417. And this is course number 5160. And the last three numbers are 093. Again, if you visit his booth before the end of the convention, there are special offers for attendance.